All right, so a couple of things I forgot to mention last week when we ran out of time is routines. So we've got a number of different routines. They're kind of a little bit confusing. If you happen to see the routines ordered, and I reflected this in a review that I posted in a Canvas on Friday. But if you see certain discrepancies between what we talk about in class and what they order, like in trauma situations or even outpatients. It's for a reason. Like sometimes you'll get an order for a 2-view C-spine. C-spine's never 2 views. It's always 3, possibly 4. Okay, so that's for a 2-view. So what we always have to have then is AP and lateral, right? So this is going to be 2-view C-spine, but you need to understand that the open mouth odontoid completes the AP. So your 2-view is never a 2-view, it's at least 3-view. So it's got AP lateral, open mouth odontoid. So what if you don't get C7T1? What do you gotta do? Swimmers, right. So swimmers, possible, but definitely those 3, and that's a 2-view. All right. So if you get an order for a 2-view C-spine, if that is your routine, the routine order in whatever clinic you're working in, that's minimum. It's actually 3-view, possibly 4-view. So a complete includes basics. So a complete would have all of this plus both obliques, and that's not anterior and posterior obliques, that's LPO and RPO or LAO and RAO. Okay, so bilateral obliques. So now they may call that a 4-view. And for whatever reason, I can't mute these in this room, but your 4-view may actually, it definitely includes open mouth odontoid. It includes both obliques, AP and lateral, so there's 3, 4, 5, and possibly 6. Okay? So always remember that the open mouth odontoid is kind of an extension of the AP. Okay, and that's kind of where we're going to start today. Is I'm skipping ahead a little bit, but that's C-spine series. T-spine series kind of has the same, follows the same rule. So that's C-spine, T-spine. Your 2-view is going to be AP and lateral, but you're never going to see C7T1 on the lateral of the T-spine. It's just not, because of shoulders. The density difference between most of the spine and shoulders is going to give you an appearance that you won't see C7T1 well if you happen to be able to see it. And so since you can't see C7T1, what do you have to do? Always the swimmers, right. So the swimmers is to the T-spine what the open mouth odontoid is to the, the swimmers is to the T-spine. There's 2 bumps in swimmers. Swimmers is to the T-spine what the open mouth odontoid is to the C-spine. It completes the lateral in this case, okay? So you only shoot a swimmers on the C-spine when you can't see C7T1, but you shoot a swimmers on the T-spine when? Always, 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 right? So then you may have a 4-view T-spine, which includes both obliques, and that's really pretty rare. I don't think I've ever worked in a hospital that routinely did obliques on T-spine in my entire career. I know some do, but it's just always been AP and lateral. So with that in mind, I'm going to bring that screen back down, and we'll get into T-spine. So we got to go through T-spine, L-spine, sacrum, and coccyx today. Really, there are not a whole lot of surprises in T-spine. One maybe, and that's the degree of obliquity, because if you're taking a test and you just completely blank on the degree of obliquity of whatever anatomy, what's your fallback position? 45 degrees, right. Well, with T-spine, it's going to be a little bit different. We're not going to use 45 degrees, we're going to use 70. And the book, I don't think it's confusing. I think it gives you both perspectives. There's 20 degrees from lateral or 70 degrees from anterior to posterior. So it's not really confusing, it's just you got to make sure that you keep in mind what it's saying. It's a very steep oblique, it's coming pretty close to a lateral. So with the T-spine, it's going to read an awful lot like chest x-ray whenever we get into the procedures. So you got 12, correspond to the ribs, occupy posterior thorax. The unique features are the costal facets that we were talking about last week. That thing is all gummed up. So it's got costal facets, and a facet is just an articulation, right? So the costal facets are in a couple of different locations. You've got on the posterior and lateral side of the body, so it actually comes in contact, the rib comes in contact with the body, but also you've got it on the transverse process as well. So we'll take a look at that here in a minute. So again, you're looking at a vertebra on a test, and it's got a hole in the transverse or a hole in the transverse process. What vertebra is that? And it's got a bifid spinous process. What type of vertebra is that?
Cervical.
Cervical, right. So you see a vertebra that has no body. That's going to be C1. You see one with a great big thing sticking off the top of it. That's going to be C2, right? And then all of your thoracic vertebrae are going to have those facets, and they're just going to be flattened areas or a little bit off color from the rest of the appearance of the vertebra. Okay, so you got those facets. So they look like that. So these are facets where they articulate with the other vertebra. These are the costal facets out on the edge of the vertebra. So a little bit boxier, a little bit bigger. But you've got those two facets. So the lumbar vertebra, we're going to have 5 lumbar vertebrae, and there's some variation there. Sometimes you'll have a patient that only has 4. Sometimes you may have a patient that has 6. It's pretty rare, but it happens. Also, what you may have is what we refer to as sacralization of L5. And that is the transitional vertebra. As L5 takes on the appearance of it looks more like it's a part of the sacrum than what it is lumbar vertebra. Okay, so they got 5, but it's just that instead of being big and boxy looking like most of your vertebrae do, it's starting to look a little bit more like it's going to be fused with the sacrum. So also with the lumbar vertebra, if the distinguishing characteristic of lumbar vertebra is that it has no real distinguishing characteristics, right? So it's going to have no hole in the transverse process, and it's also not going to have rib facets, costal facets, right? So if you don't see any of those on a drawing, then it's got to be a lumbar vertebra, right? So that's what it looks like. Much larger, and we'll kind of get into the significance of the inferior vertebral notch on both the lateral T-spine and lateral L-spine. Okay, so the sacrum, we're not going to get tied up in a lot of the anatomic features, promontory, canal, all those things. So what we do have, though, is a articulation with the iliac bones. All right, so that's what we refer to as SI joints. So people will get arthritis or some sort of irritation at SI joint, and that's one of the other places aside from your facets that people will require injection, some sort of steroid injection to relieve pain. So the demographic here is, the patient comes in, they're complaining of pain, and it's kind of like it's kind of in my butt cheek, but it's deeper than that, I sit for too long, and then I get up and I have this pain right there, and they point directly to their butt cheek. So that's probably an SI joint issue. We'll take a look at what that looks like on not the pain, but the articulation here in a second. So the coccyx is kind of your tailbone, and it's all the way down at the bottom. So you've got 3 to 5 coccyx segments, and they're all fused together. So all the sacral segments are fused together, and then all the coccyx segments are fused together. The two are not fused together, the sacrum and the coccyx, and you can actually, I guess you call it dislocation. You can actually have, disarticulation between the coccyx and the sacrum. All right, so it looked like that. So you got 1, 2, 3, 4, 5, and then down here is the coccyx, and you've got between 3 and 5 of the coccyx segments. Okay, so you know all this, dress your patient. And I'll remind you, like when we went through KUBs, to not trust sweatpants, right? So go ahead, if the patient's in sweatpants, especially if it has a zipper, that zipper's got to get out of the way, because a toggle on the zipper is always metal, even if the zipper itself is plastic, so it's got to get out of the way. Also, your sweatpants have so much elastic that it's going to show an artifact, right? And it might distort the skin as well. You know, you put on sweatpants and sometimes it's the elastic is so stiff that it kind of pushes into you. So your best bet here, you don't necessarily have to dress your patient, but what I recommend that you do is first get a sheet and put it over your patient, and then tell them to lower their pants, right? Don't tell them to lower the pants first, because they will, but put a sheet over them, then tell them to lower the pants. So all the other things, remain the same. You don't necessarily have to get necklaces off of the patient for L-spine, but you would have to for T-spine. You can put them in a gown if you want to. You can do it upright or, with the patient laying down. It doesn't really matter. I prefer with the patient laying down for one big reason is that you got to keep in mind your curvatures in the spine. With the patient upright, those curvatures are going to be exaggerated. With the patient laying down, curvatures kind of flatten out, especially the lumbar curvature, and I'm going to tell you how to further flatten that out here in a minute. So trauma patients, don't move them, and your lateral is probably going to be cross table unless the patient is cleared. So most of the time it's going to be 40 inches. Most of the time your collimated field is going to be 7 by 17. I think your current issue says 8 by 17. Okay, whatever, it's another inch. Also though, you need to understand a couple of things. One is that whenever you're in a trauma situation, if we're starting to move back into shooting spines, we have a tendency to think, well, the first spinal view that we need to do is a lateral C-spine to clear the C-spine. That's not true. That's the first image that we shoot typically after we shoot a chest x-ray. Okay, so we shoot a chest x-ray. The chest x-ray becomes the AP of, that was probably loud on the recording, but it becomes the AP of the T-spine. Okay, KUB becomes the AP of the L-spine. So we don't have to shoot, chest x-ray, AP T-spine, L-spine, and KUB. So it's just two views. And following that out a little bit more, some docs prefer you not to shoot collimated AP T-spine, AP L-spine. And they've got legitimate reasons for it, and they're the ones that are paying the malpractice suits and all that, so we do what they want, right? So if you were working with a doctor in a hospital that doesn't routinely do a collimated T-spine or collimated L-spine, that's fine. What we're looking for specifically on the T-spine is vertebra, but what the doc may be thinking that the patient may have is something close to the vertebra causing a pain that the patient thinks is back pain, when in fact it may be something else, right? So maybe they've got some sort of pathology just lateral to where that collimated field would be that they won't see, right? For example, if a patient has a gallstone, so gallstone, presence gallstone, that's what we call cholelithiasis, and we'll get into that next semester, but presence of gallstone is not a problem. A lot of people have gallstones, they don't even know it. And they don't know it because it stays in the gallbladder. But if it comes out of the gallbladder and it goes into the neck and down into the biliary tree, then it causes a lot of pain. Pain from pressure and, just presence of stone in there. So the gallbladder is kind of lateral, right? So, and the gallstones, most of them are pretty radiolucent, but some of them are pretty radiopaque. So if a patient's complaining of back pain and they're not specific of where the back pain is, and we just shoot a KUB, and a radiologist hardly ever sees the patient, and we just shoot a collimated APL spine, and the patient's actual pain is from a gallbladder or a gallstone or a kidney stone, we're going to collimate that off. Okay, so the legitimate reasons not to collimate, but if your hospital and your doctor don't specifically say, I want, chest X-ray for a APT spine and a KUB for an APL spine, then you collimate. Okay? All right, so 7x17 on most patients will be adequate. I think your book is made to shift to 8x17. So use markers, radiation protection. Also with radiation protection, there's one more step that you may see technologists use. It's not really radiation protection, it's just to clean up the image. Let's say you're shooting a lateral T-spine or lateral L-spine, you're going to create a lot of scatter, right? So the things that create scatter are the tissue thickness and also the KVP level that you use. So we're going to drop our KVP back. We're using 110 KVP for chest X-ray. We're going to drop that KVP back to probably 80 or 85. We're still shooting through a lot of tissue, right? So we're going to create a lot of scatter radiation. And since we're collimated down to 7x17, some of that scatter is going to be projected off of the collimated area, but it's still going to show up on the image. So to clean up that image, what you may see the technologists do is take an apron or lead sheet or something. If it's an apron, they may double it up and lay it behind the patient to absorb some of that scatter radiation that would strike the image receptor, and it just blocks it from hitting the image receptor. You can't put it in front of the patient, but you can put it behind the patient. So you may see that happen. The purpose for that in a digital world is every X-ray photon that strikes that image receptor goes into the calculation of your index number. Okay, so your index number gives you an idea how much radiation the patient received, and that might be cheating the index number in as much as it's given the image receptor indication that the patient received less radiation. But the other thing that it does is it affects the computer algorithm, and it determines the computer algorithm is what determines what your contrast and density is going to look like. So if we can get rid of some of that scatter radiation, it gives us a better image. Is the short walk to that long explanation. Okay, so you're going to see technologists do that quite a bit, and it's reflected in your textbook on page 453. All right, so essential projections of the T-spine. We're going to talk about the obliques, but we're mainly going to focus on the AP and the lateral. So AP and lateral, and then we've got the obliques. Again, we'll talk about that. So your positioning is going to be very similar to a chest X-ray. Where do we position the top of the image receptor for the chest X-ray?
2 inches above the shoulder.
1.5 inches, 2 inches above the shoulder. So how many vertebrae do you have? 12. How many vertebrae did you have for chest X-ray? 12, right? So 12 ribs, 12 vertebrae. You're positioning the top of the image receptor for AP of the T-spine is going to be exactly the same spot. Where was our central ray for chest X-ray?
3 inches below the jugular notch.
3 inches below the jugular notch, going right through the T7. Yeah, 7th thoracic vertebra. So where's it going to be for this? Exactly the same spot, right? So where we've got some differences in positioning of the T-spine and the chest X-ray, and your questions, how they may come to you, is that because of the difference in thickness between the upper and the lower thoracic spine, really the tissue between the upper and the lower thoracic spine, we need to take advantage of the anode heel effect. Are y'all familiar with that? Okay, so greater intensity on the cathode end of the X-ray tube, so you want to put the thicker anatomy towards the cathode end of the X-ray tube. Okay, so that's number one. Number two is that if you can't utilize that, then what you might want to utilize is a compensating filter. A compensating filter in this case would just be a wedge shape. So you put the fat end of the wedge over the upper portion of the T-spine, thin end of the wedge under or over the lower portion of the T-spine. okay? So, you know, look for those type of questions. But everything else is pretty much the same, aside from collimation. Collimate down again to 7 by 17. So shoulders same horizontal plane, arms side by side. Make sure that you get a good look at the patient. You know, if you put a gown on or a sheet on the patient or a blanket on the patient, make sure you get good eyes on the patient before you make your exposure. Make sure that they didn't put their hands across their belly, just like what we talked about on KUB. So center mid-sagittal plane, we just talked about all that. Perpendicular central ray. Okay, so one significant other difference between AP chest X-ray and AP T-spine, and this applies to L-spine too, is you want to bend the patient's knees. All right, so when you lay flat on the floor with your legs extended, because of the lordotic curvature in your L-spine, you've got a gap, right, between your back and the floor. But if you bend your knees, what happens to that gap? Yeah, it decreases, right? So both on the AP of the T-spine and the AP of the L-spine, what you need to do is bend the patient's knees up. Bend their knees up to, you know, bring in this case, the lower portion of the T-spine down, okay? On the L-spine, it's gonna be to reduce the lordotic curvature of the L-spine. So what we're going to look for is now, instead of 10 ribs, we're going to look for 12 thoracic vertebrae. And it may be easier for you to count from the bottom up than the top down. So what are you going to look for on that last thoracic vertebra to count up? Okay, L1. L1 has a lack of ribs, right? So look for L1 or look for the last rib, right? And then you can count up. Because 1 and 2, the first 2 ribs are a little bit tough to distinguish from each other, right? So it's a little bit harder to count from the top down, so you may want to count from the bottom up. So it should look like that. You see the difference in density, higher density, darker image, up at the top, down at the bottom, not quite as dark. That will be your last rib, remembering that our last 2 ribs are floating ribs. They don't have any kind of attachment. Very short, right? So your 12th rib is very, very short. So your lateral, what you want to do is have the patient be very specific with your instructions. Tell the patients to roll all the way up onto their left or right hand side. It doesn't really matter. Most of the time we're going to do left, just because we do left on pretty much everything. Right, but if a patient says I can't lay on my left-hand side, then right-hand side's fine. You know, there's no great benefit to the right lateral versus left lateral. Just make sure you mark it correctly and annotate that you shot right lateral. All right, but have the patient stack their knees on top of each other, because what you'll find in a lot of cases is patients laying there. I know this isn't going to show up on this. But patients laying there, you tell them to roll up onto their left side, and they'll roll everything except for one leg will be behind the other, right? And what that's going to do is it's going to rotate the lower L-spine. So if you put their knees and their ankles on top of each other, put their arms straight out in front of them, you know, you can tell them, act like you're praying or whatever, put their arms straight out in front of them, you can even have them, you know, join their hands like that. Look at them and make sure that their shoulders are kind of stacked, because even with this, sometimes you'll get a little bit of rotation. So try to get a good look at the patient and make sure the shoulders are on top of each other for your lateral. And then what you're going to look for as far as where to put your central ray is you're going to look for where their arm joins essentially to their thoracic cavity. You're going to go just below that, okay? So probably the most common mistake that I see people make on a lateral T-spine is that they would try to put the central ray directly in the center. And they didn't make this mistake on L-spine quite so much, but try to put the center more like chest X-ray, right in the center of the thoracic cavity. Collimate down to 7 by 17, clip the T-spine every time, all right? So just that little fold right there, if you go just distal to that, centering right around the bottom of the scapula, T7, you're gonna hit it every time. And if there was an exam that I would recommend that maybe you open your collimators a little bit more than what the textbook recommends, this would probably be it. Because you just don't know what's going on under that skin. You know, is the patient partially kyphotic? You know, if so, you might clip the upper portion of the T-spine. Also, always look at the AP before you shoot the lateral, just like on chest x-ray. If you have an AP chest x-ray and you see that the patient has some degree of scoliosis, they're gonna be rotated on a lateral, and there's nothing you can do about it. So just understand that your lateral is gonna come out and it's gonna have some rotation, but your assessment of that rotation is gonna be similar to a chest x-ray. Make sure those posterior ribs are superimposed. Okay.
What is the SID on it?
40 inches. Yeah.
Yeah, in the book it was saying that 48.
48.
Mhm.
Yeah, you can back up to 48 inches. You got an increase in OID, but I think a lot of your technologists can just shoot 40 inches. So lateral T-spine, the one other thing is that what we're going to utilize is a breathing technique. Okay, so like the Ottinello method, you know, wagging jaw, what we're going to do is use patient motion to get a better image of the T-spine. So what you're going to do is you're going to set up your machine. If you have a good technique, then I recommend you set a technique. If you don't have a good technique, then what you can do is, depending on the equipment that you're using, some of your equipment, you know, if you hit T-spine, it might give you, let's say 300 MA. With 300 MA, your exposure time is going to be short, right? You're not going to be able to use a breathing technique. Some of your machines will allow you to still photo time and decrease the MA. Okay, so you just reach up and decrease the MA. What you might do also, another option, is to not use those presets, but select the center cell and select the smallest focal spot that you can select. And you're still phototiming. So you select that center cell, lowest MA that you can select, and you're still phototiming. It's going to give you a long exposure time. And if none of that works, let's say you're shooting portable, you're shooting with a portable, it's also going to be a big exposure. So it's going to be, you know, 80 mass minimum, most likely, unless you got a little bitty patient. You know, you got a real small patient, maybe less than that. But 80 mass, you can get almost a full second, right? So, you know, if you're doing a portable, you got a mass timer, 100 MA is 0.8 seconds. So what you would do is have a patient taking a big deep breath and tell them slowly blow it all the way out. And while they're blowing out, make your exposure. It's kind of a limited breathing technique, and it's not gonna, you know, make it look quite like that. I don't want you to fall asleep, but I want you to be able to visualize this a little bit better. You know, picture in your mind a lateral chest x-ray and what the vertebrae look like on a lateral chest x-ray. They're just covered with lung markings, right? You just can't see them all that well. So with this, we've got the moving of the lung markings, and you can see them a whole lot better. So, breathing technique. Long exposure, maybe 3 seconds if you can get it. What's that?
Is the Antonello going to be on the test? Because I don't remember going over
It's
that.
not, you know, that's actually a very good question. I think it was on last year's. I don't know if Mindy's going to, you know, edit the test or not. So,
is it the same as an AP, just them?
Very similar to AP, just with a moving jaw so that it blurs out C1, C2, or blurs out the mandible over C1, C2. Okay. All right, so typical T-spine fractures, they're generally going to be compression fractures. And so with the compression fractures, what you get in a lot of cases is an exaggerated kyphotic curvature. But compression fractures also, sometimes what will happen is it will introduce some degree of scoliosis. Is, you know, trauma scoliosis is what it amounts to. But what you'll see sometimes, you notice older patients sometimes have You know, they had great posture when they were younger, and the older they got, the more hunched over they became. Some of that's musculature, but some of that could also, especially in osteoporotic women, could be due to compression fractures in their T-spine as well. All right, so you're going to have probably the most difficult portion of this test is what do you see on your, really between your laterals and obliques. So let's start with C-spine. All right, let's do it like this. Let's do obliques and lateral and side. Okay, and then we're gonna go C-spine. What did we see on our obliques to the C-spine?
The intervertebral foramina.
Bingo. Intervertebral foramina. And so if we saw the intervertebral foramina, what did we see on the lateral? Zygapophyseal joint. Okay. So on the obliques, you know, we can shoot AP or we can shoot PA. On the obliques, if we shot the AP, which intervertebral foramina do we see?
The side up.
The side that's up, right. All right, so AP, up. So what does that mean if we shot PA?
Down.
Yeah. PA, we would shoot and we'd see the downside. All right, so with our obliques of the T-spine, I can't really bring this back down, but with obliques of the T-spine, I'll bring the lateral back up and you can see it. Obliques of the T-spine, everything changes. Okay, so what we get on the obliques of the T-spine, well, let's, so T-spine, on the obliques, what we're going to see is the zygapophyseal joint. Okay? That means on the lateral, what are we going to see?
Foramina.
Intervertebral foramina. Okay? Now, foramina. All right, so where we're going to see our zygapophyseal joints on the T-spine follow the C-spine. So the AP is going to be on the upside and the PA is going to be on the downside. Okay. Now, so I don't have to drive these back up here in a bit. On the L spine, we're going to make another change. Okay, so the spine doesn't really just change from one end to the other drastically. You know, it's a slow change. Lower C spine looks like upper T spine. Lower T spine looks like upper L spine, and so forth. Okay, so on the L spine, we're also going to see the zygapophyseal joint on the obliques, and on the lateral, we're going to see the intervertebral foramina. Try to do it again. But this is going to switch. So AP is going to be on the downside, and PA is going to be on the upside. Okay? So that's probably the most complicated portion of spines right there, is where do I see what on which exam type. And bringing back up the lateral T-spine. Okay, so that just blinked. Computer's out for now, but if you flip over to page 458, okay, that's better. I don't know if I ever told you why these things go down so much. It's because when they built this building, they had a lot of different potential Wi-Fi addresses, and they didn't dedicate any of those to any specific classroom. So when the population of the building gets up and more people are accessing Wi-Fi, it will bump a room off if something's, somebody else tries to access it, and you can't control it. So this is a lateral, so notice on even the upper portion of the L spine, lower portion of the T spine, you see a great big gaping hole there? Yeah, that's your intervertebral foramina. And I'll point out the zygapophyseal joints whenever we get to the L spine. Okay. So the obliques, again, I'm just going to touch on that. Obliques of the T-spine are going to be very steep obliques. They're almost going to be lateral. They can be PA, they can be AP, it doesn't matter. It's going to be 20 degrees from lateral, which puts you at a 70-degree oblique, okay? Which means this is lateral. You can point your feet straight at that wall over there, that's lateral. So this would be like 70-degree oblique, very steep oblique. So what you would do is you would off-center, intentionally off-center, just towards the elevated side to make sure you go through the, like an inch and a half towards the elevated side to make sure you go through the front. So our L spine, we're going to have AP lateral. L5S1 spot is not something that we're going to do on every exam. And then we've got the obliques. All right. And we're going to talk about SI joints as well. So our APL spines, depending on what your hospital protocol is, again, you may shoot a KUB for an AP of the L spine. Some hospitals may require an AP of the L spine to include sacrum and coccyx, in which case you're going to use more. You're going to have a larger collimated field. So you're going to open up the vertical access of the collimated field to make sure you include the sacrum and coccyx. So know what your protocol is. If you're looking for the sacrum and the coccyx, you're looking for the entire lower portion of the spine, then what you're going to use is positioning at the iliac crest, just like a KUB. So you're going to position at the iliac crest. The length of your collimated field is going to be 17 inches. So you're going to use the entire length of the image receptor, center at the crest. If your hospital protocol is just to show the L spine, then you're going to center about 1.5 inches above the crest, and your collimated field is going to be more like 14 inches. Okay. So know your routine. Make sure you bend the knees to straighten out that lordotic curvature. Your mid-sagittal plane is going to be parallel to the central ray. Mid-sagittal plane perpendicular to the image receptor, coronal plane and parallel to the image receptor, coronal plane perpendicular to central ray. Make sure the hips are in the same horizontal plane. So you can put the patient's arms across the chest. Really just, it doesn't matter where you put them, just make sure that they're out of the way. Make sure that you get a look at the patient before you make your exposure to make sure that they hadn't put their hands across their stomach. Okay. So all this is what I was talking about before. Know your routine, position accordingly, and what it should look like is that. Okay. So a little bit difficult to count, from the upper portion. A little bit difficult to see the separation between L5 and S1. But what you're going to look for is to make sure that you include whichever anatomy it is that you're supposed to include, sacrum and coccyx or just L spine, but look for that lower vertebra. Okay, so gas patterns and feces kind of wreak havoc on an L spine. Okay, so we're at 8:50. Why don't we take a break? Come back at 9. And we'll finish everything else back up.